All right, here's EMS 270, the Medical Cases Course, Lesson A. Overview, we're going to talk about nausea, vomiting, diarrhea, abdominal pain, with or without GI bleed issues. Talk a little bit about some of the OB/GYN causes of abdominal pain in those specific cases. And then we're going to talk about differential diagnosis versus the management plan, the idea being there that while we may not ever be certain in the field of what the exact cause is, the management plan is pretty much the same. So these turn out to be relatively straightforward cases. Nausea and vomiting certainly is uncomfortable for the patient, can certainly have airway impact. We would like to not have nausea. We'd like to not have vomiting. Not always something we can control. When you have protracted episodes of vomiting, you can actually get into a hypovolemic situation. Everybody loves Zofran. Ondansetron may not stop vomiting. It's great for nausea, but there may be other meds that you will carry, maybe a Compazine or a Phenergan, and in some cases Haldol has been helpful, particularly for those patients that are having a lot of vomiting secondary to marijuana use. Interestingly, it doesn't make a lot of sense, but it just is what it is. But almost all services are carrying ondansetron in some form now. Just wanted to make sure you were on board with the idea that ondansetron is great for nausea, but may not stop vomiting once that has started. Then patients that have vomited a lot, you want to consider that they may be low on glucose. They're not able to eat, and so they may have dropped their sugar, whether or not they're diabetic. And then another big thing is always consider that this is a coronary event. Nausea and vomiting are a big indicator of severity in a patient with acute coronary syndrome. And so if it's an MI, then it may present without a lot of chest pain or without any chest pain. It may just present with the GI symptoms. Diarrhea, again, can be a problem with hypovolemia when it's extreme, and can get into hypovolemic situations with pediatric patients a little quicker, perhaps, than with adults. So consider that volume loss. And then also consider that they're not just losing volume, but they're also losing electrolytes. And they can diarrhea can produce some derangement in their electrolytes and their potassium and their magnesium and such, which can end up causing some cardiac rhythm problems. So in contrast to chest pain, where a patient's chest pain is really, the severity of their chest pain is really not proportional to how serious the cardiac event may be, abdominal pain's not so. Abdominal pain, if they're hurting a lot, it's a big deal. If they're not hurting a lot, it's less likely to be a big deal. And then with abdominal pain, you can have referred pain. So the patient who is complaining of pain in the right lower quadrant may not have a problem in the right lower quadrant. Conversely, a patient who has a right lower quadrant issue may end up with weird referred pain, such as left shoulder tip pain or something like that. So the location of the pain is not really related to the location of the problem in every case. The severity is usually proportional. Some services allow you to do pain control. Some will, by standing orders, some will require that you do medical control. Sometimes those requests for orders will be denied, sometimes not. In many cases, if you can make a strong case for this being likely kidney stone pain, then pain control is pretty common. But in other cases, they may want to hold off on pain control, and this is difficult for our patients, difficult for us to deal with, but it is what it is. In other cases, different protocols have standing orders to allow some pain control for these folks. Always consider the killers. If a patient has a gallbladder issue or they have a bowel issue or something, these are infrequently a life threat. But what if it's a abdominal aortic aneurysm? What's a AAA? And so we want to consider these things in all cases. And you can sometimes palpate, particularly around their belly button, and feel a pulsatile mass with a AAA. Sometimes not. But just want to have AAA in your mind, maybe not even in the back of your mind, but in your mind as a potential cause here. Then abdominal pain can also be an indicator of a GI bleed. And certainly if a patient is vomiting blood, it will, partially digested blood will look like coffee grounds in the emesis, And so hematemesis is bright red blood in the emesis, and then coffee grounds, excuse me, coffee grounds emesis is a legitimate medical term. You can say that, and it's not that it's a slang, it's an actual term. And that's with emesis, that's with what they're vomiting. What does it look like in their bowel movement? So you can have frank, obvious blood in the bowel movement, and that's called hematochezia. Or you may end up with more of a dark, tarry stool, a melanic stool, signs of melena. And so these are all terms that you should know in order to be able to converse with medical professionals about all this. Realize that there may be blood present in the emesis or in the stool that you can't see, but can be detected with a quick and easy test in the ER setting. And then there's other sources that can cause bleeding. A patient with significant hemorrhoids can have blood on the toilet paper or in the stool, and it's not really a GI bleed, it's more of a surface injury. So your plan, well, there's all kinds of possible differentials for these folks. It could be probably a half dozen different things, and then when you add a woman of childbearing age to it, you can add another 3 or 4 things to it. And I don't think that we're really going to know for sure in the field, but that's the good news is it doesn't matter. Your field management plan is exactly the same, regardless of your diagnosis. And so while in the ER they'll get it right, they'll have advanced imaging, they'll have some lab results, they'll have some surgeons, and they probably have more experience with these sorts of matters. And so they'll probably get to a differential. They'll probably get their differential list down, and they'll probably get to a diagnosis in the ER. We probably won't in the field, but that doesn't matter because the field management plan is the same. Again, don't forget this could be a cardiovascular problem that's showing up with GI symptoms. Don't forget that these folks can be hypovolemic. They can lose enough volume through vomiting and or diarrhea to be hypovolemic. And remember that hypovolemic shock is based on assessment of signs and symptoms, and it has nothing to do with blood pressure. It's all about heart rate, cool, pale, clammy skin, and the history of the present illness. And then consider there's some possible OB/GYN sources for abdominal pain. You can have ovarian cysts that can rupture or not. You could have other issues with ectopic pregnancy or something, so they don't have to have vaginal bleeding in order to have an OB or GYN source for this. It can just show up as abdominal pain. So your prep for the lab in this is pretty straightforward. Review abdominal pain, nausea, vomiting, diarrhea, and it's great to go look at specifics on cholecystitis or kidney stones or any of the multitude of things, as long as you don't let this distract you and you attempt to become a diagnostician and figure out exactly what's going on in the field when you don't have the benefit of all the additional analytics that you need in terms of imaging and lab work and such. So it's great to have an idea what it is, but don't be distracted by that. And some background knowledge never hurt anybody on this stuff. Management's simple. See if they're low on volume, see if they're low on sugar, see if they're low on lights. Wouldn't be bad to have a 12 lead on a lot of these folks at an appropriate time. Low MAG, low or high K can cause you some cardiac rhythm problems. And then always remember that it could be that aortic aneurysm. Keep that in the back of your mind. We're going to run a couple of scenarios. We're going to run a couple of scenarios with this. The first one's going to be fairly straightforward. 65-year-old guy with belly pain, has some nausea and vomiting, no diarrhea, nothing complicated in his med list, no GI bleed symptoms. So really, it's a matter of, is he low on volume? Is he low on sugar? Is this a AAA or something else? Is this a cardiac thing? And we'll practice managing that efficiently and effectively. And then this is the exact same guy, again, no complicating meds or anything, but now he does have some GI bleed symptoms. Maybe he's got some coffee grounds emesis. Maybe there's frank blood in his emesis or in his stool. Maybe he's had some dark tarry stools, but we'll add in some GI bleed symptoms. And again, it's the same thing. It's hypovolemia. And now we have more of a concern. Now he's not just lost volume from vomiting. Now he may have lost blood volume from a bleed. And so, again, replacing volume is the key. Don't forget it could be cardiac. Don't forget it could be a AAA, and manage that guy. And then this patient would be the female patient, the woman of childbearing age. Same presentation, no complicated meds, no GI bleed symptoms, but we need to help you practice some additional history there. Last menstrual period, location of the pain, is there any vag bleeding, those sorts of additional history clues while you deal with hypovolemia, hypoglycemia, rule out a cardiac cause. Of course, in this setting, it doesn't seem likely, but you should always consider it. Could there be something else going on, AAA or something like that? So 3 quick scenarios designed to get you some reps, exercise your ability to recall this information and not be distracted trying to figure out exactly what the cause is. It's nothing wrong with thinking about that, but as long as you're managing everything else. And so those are the big keys for Lab A for 270.